Hello. Good day, dear colleagues. I'm Dr. Jihad, and our today's lecture is a continuation of the series that we have started, What Surgeons Should Know, and it's about the appendix. And as a brief introduction to this lecture, I feel that appendix and similar subjects in general surgery, similar common subjects in general surgery, such as cholecystitis, pancreatitis, are frequently daily practiced in general surgery, but they are theoretically underestimated. This is because we feel that we can manage everything, but when we go deep in the theory, we find a diversity of information, a diversity of entities and diseases that we should know. Okay. This lecture will be divided into two parts. The first part, we are going to talk about the appendix, anatomy, physiology, pathology, classifications, appendicitis, etc. And the second part, we are going to talk about appendiceal neoplasm and tumors. Okay, as I always advise you to pay attention more to what I say, despite that I'm suffering now from upper respiratory tract infection, but pay attention more to what I say than what's written. I will highlight the most important topic. Okay, if we are talking historically about the appendix and how humans recognize that right iliac fossa pain can be due to the appendix, is just at the end of the 16th century when the artists start to mention the appendix on their anatomical drawing, and one of the most popular is Leonardo da Vinci, who mentioned the appendix as the valve to the cecum, as you can see here. That's around these dates, actually. Okay. If we are going to talk deep in the history, it's just who described appendiceal disease. He was first who described the appendiceal disease, not the classic appendicitis, that there is appendix and it could be the cause of mortality and morbidity. He was Jean Fernel. Actually, he is a doctor who treated a patient with conservatively, and she dies, a girl conservatively, and she dies due to right iliac fossa pain, and on autopsy he found an obstructed lumen of the appendix. The classic description of appendicitis was by Lawrence Hester in 1711, and the first man who performed appendectomy was Amyand in London in 1736. Yes, I know that most of you knows what is Amyand hernia. Actually, this surgeon operated a boy with hernia, and in the hernia he found an appendix. Actually, he removed the appendix, and so he was the first man who performed appendectomy. And yes, Amyand hernia, it's the hernia where the appendix is in the hernial sac. Okay. Before this date, it was acceptable diagnosis that right iliac fossa pain is due to typhlitis and peritaphylitis. Actually, typhlitis and peritaphylitis, these are inflammation of the cecum with the different etiology: chemotherapeutic agent, neutropenic, viral, bacterial. It's inflammation. But from this date and on, the humanity start to recognize that there is appendix, and the first man who recommended operative treatment for appendicitis, it was in 1886, was Fitz. Okay. McBurney actually published a landmark for the appendectomy, and he described the indication for laparotomy for patients with appendicitis. Okay. And so we started to do appendectomy at the beginning of the 20th century. We started to do appendectomy, and the question was, should we do, at that time, should we do an appendectomy for every patient with appendicitis. The problem was with those patients who presented with perforation, and so we cannot expect who will present with perforate or who will have a perforated appendicitis as a consequence of his appendicitis or will respond normally. And so appendectomy were performed classically routinely for all patients with appendicitis to prevent, because we cannot predict patient who will present with perforated or who will have perforated appendix later on. It took a long time until the 1970s when we have a large number of negative laparotomies and we start to think, can we manage the appendicitis conservatively, because we have many negative laparotomies. And we will see later in this lecture that early appendectomy, just because we fear of perforation, does not decrease in mortality and morbidity. And so since the 1970, the number of laparotomies and appendectomies is decreasing a little bit. Okay, this was just a brief introduction to the history. Let's move to the embryology of the appendix. Okay, and regarding the embryology, it actually at the 6th week of the human embryonic development, the appendix and the cecum appears as outpouching. The appendiceal outpouching, actually it's at the 8th week and it takes to the 5th month to achieve the appearance of vermiform appearance. Okay. Regarding the embryology and the disorder in the embryological development, we have the malrotation and volvulus and situs inversus. For example, you can see here, this is the normal location of the appendix. It's in the right iliac fossa pain. Here in malrotation, it's located in the upper abdomen, and here is in volvulus, it's displaced. And you can see here in the LAD procedure we do what we call it incidental appendectomy. We will discuss it later on. Situs inversus, it's actually when we have a mirror for the organ. It can be situs inversus of the abdomen, situs inversus of the chest. It can be both. You can see here the appendix is located in the left side. These are the three main entity where the appendix is located in an odd location: the malrotation, the volvulus, and situs inversus. As we said in the development, it's actually in the 6th week we have the outpouching of the cecum and appendix. In the 8th week we have the outpouching of the appendix, and in the 5th month we have the definitive appearance of the appendix. Okay, about the anatomy of the appendix. Okay, and about the anatomy, actually the appendix is located at the end of the cecum. You can see here at the end of the cecum where the 3 tinea coli joint, and this is an important and have a clinical significance. This is actually the tinea coli. There is other 2. When they meet together, when they join together, we have the base of the appendix. We have the base of the appendix, and actually it is 2 centimeters below the ileocecal orifice. This is the ileocecal orifice, and it's about 2 centimeters below the ileocecal orifices where the 3 tinea coli, this is one of them, there are other 2 joined. We said that it have a clinical significance. Actually the base is fixed in its location. It's constant in its location. It's where the tinea are located, so it helps us intraoperatively to find the appendix, because the tip, it can be anywhere. We will see the different location of the tip of the appendix, but this will help us in finding the appendix. The average length of the appendix is from 6 to 9 centimeters, And the diameter of the appendix, if we are talking about the outer diameter, it's about from 3 to 8 millimeter, and the inner diameter is 1 to 3, called the luminar diameter, from 1 to 3 millimeter. Actually, this number, the problem with them, they have no clinical impact on the diagnosis, if we, or yeah, on the diagnosis, because even in the CT, we cannot depend on the diameter alone. We will see the outer or inner or the length of the appendix to call it that this is appendicitis or not. But theoretically, to know the length is about 6 to 9. How we can say it, the long appendix ever noted, it was in, I think in one study I read it, it was 25 centimeter. Okay, the anatomy, or the blood supply of the appendix, it's from from the appendicular artery. It's a branch from the ileocolic artery. You can see here the inferior division. Here we have the ileocolic artery, we have the superior division, we have the inferior division. It gives us the inferior division of the ileocolic artery, gives us anterior and posterior cecal artery, and here you can see the appendicular artery. It's an end artery, so it can get thrombosis and lead to gangrenous appendicitis. Here is the location of the tip. You can see the diversity of the location of the tip of the appendicitis, but the base is fixed, as we said, where the tenii meet. Okay, the most common site for the appendix, it's about 25%. It is retrocecal. Where is it? Here it is. You can see here they are classified as an o'clock. Here is the 1 o'clock post-ileal. This is the ilium, this is behind the ilium. Here, anterior to the ilium at 2 o'clock, 5 o'clock in the pelvis, 6 o'clock subcecal, and retrocecal. We said that the retrocecal is the most common. So other location is the subhepatic. Difficult for the surgeon to reach it from the classic appendectomy incision. Another location for the appendix to be subserosal, under the serosa of the cecum. So it's difficult to remove it and even to notice it. Okay, the lymphatic drainage, it follows the artery. It follows the ileocolic artery. You can see here, this is the lymphatic drainage of the appendix. Here we have the appendix, we have, it goes back, we have the lower group of the ileocolic node, and the upper group of the ileocolic node. Eventually they meet at the superior mesenteric artery lymph node. The histological features is similar to the this on the colon, histological feature of the colon, except in that there are many, you can see here, many lymph nodes aggregation. These actually lymphatic nodule, and we have lymphatic aggregate occur in the submucosal. This is the submucosal layer. Okay, and so because of these lymph nodes, sometimes they call it the abdominal tonsils. Okay, Bayer patch also called the abdominal tonsils. Okay, lymphatic channel are prominent in the region underlying the lymph. Okay, we said that. It's not, you have also to recognize that there is in the appendix what we know, the neuroendocrine complex, the Schwann cells, the neural fibrosis, neurosecretory cells. This will lead us to neuroendocrine tumor eventually. We will see later. Actually, this is the lining of the epithelium. Here is the muscularis mucosa, the lamina propria. Here is the outer layer. Actually, we can see here three following layers. The outer is the serosa, which is an extension of the peritoneum. The muscularis layer, which is not well defined and may be absent, and finally the submucosa and mucosa. These are the three layers of the appendix. Okay, about the physiology. And about the physiology, it was thought that the appendix is just a vestigial organ. Vestigial organ means an organ that present in the human body with no function, and in our old humans or primary first human, it had a function, but this actually is not 100% true, because we found that there is a function for the appendix in the human, and of this is the secretion of the immunoglobulin, especially immunoglobulin A, and there is some unclear associations between, for example, the appendectomy and the protective effect on ulcerative colitis development, the appendectomy and the exacerbation of Crohn's disease. Despite these are not well understood, but this means that there is a role for the appendix more than the immunoglobulin A secretion. Another role for the appendix is the it functions as a reservoir to recolonize the colon with a healthy bacteria. One study found that patients who have appendectomy have a high risk for developing Clostridium difficile infection. Yes, this is a study. There is another study that proves that this is not true, but we can say unclear function for the appendix till now. What we know, it has an immunoglobulin secretion. It's not just a vestigial organ which had a function and now with no function, such as the coccygeus, for example, in the human being. Okay, about the epidemiology, we can find that it's a little bit slight. The incidence is high in male, or the lifetime risk for developing appendicitis is high a little bit in male. It's about 9 and 7 in female. It's the highest incidence in young, in the second and third decades. It's not in the newborns or children's. It's in the youngs in the second and third decades. It's common in white, and it's common in May, August. This variation and so-called the epidemic appendicitis. Okay, duplication of the appendix. Yes, the appendix can be duplicated. We can have in a one person two appendixes. Do we have an entity called absent appendix? Yes, it's extremely rare. Agenesis of the appendix is extremely rare, and I think that the problem that we practice appendectomies as new residents, junior surgical residents, and while performing appendectomy, when we do not find it in our first attempt, we start to think, is this agenesis? So we overthinking of agenesis. With patients, we will find the appendix. If it's absent, this is an extremely rare cases in the human being. Actually, let's return to duplication of the appendix. It's Wellbridge classification. You can see here type A, where we have partial duplication with single cecum. Actually, you can see here single cecum, and you can hear the paired peak appendix. We have one appendix here, we have appendix here. Type B, we have two separate appendicitis from single cecum. You can see here, this is an appendix, this is an appendix. And type C, we have C double, actually CD double, CD double, we have double cecum and double appendicitis. Okay. Actually, the opening between the appendix and the cecum is guarded by the valve of Geralge called. Here is it. Orifice of the appendix. This is the valve of Geralge. Okay. The etiology, we will figure this when we come to the classification of the type of appendicitis. But here they mention that fiber-rich diet prevent appendicitis, less fiber-rich increase the appendicitis. Viral infection, how can viral infection cause appendicitis? It's actually cause mucosal edema and obstruction of this valve, and so there will be obstruction, or there will be bacterial, superimposing bacterial inflammation and mucosal inflammation, and will lead to appendicitis. There is a family history, 30% of children who presented with appendicitis have a first degree relative with appendicitis. We said obstruction is one of the causes. Actually, the appendicitis, we will discuss it later, can be mainly classified to obstructing and non-obstructing appendicitis. The obstruction can be, as we said, by if viral infection causes mucosal edema, so the valve will close and we will have obstruction, but it could be fecalith type of stool material. Feces can block this lumen, and this is the most common, by the way. Stricture, foreign body, worms, these all cause obstruction. Adhesions, kinking of the cecum, Crohn's disease, as it's most likely to be in the ileocecal region. Distal colonic obstruction will cause stasis at the ileocecal region and will cause obstruction. Abuse of purgatives, fecalith is the most common cause. The organism which will be cultured in appendicitis is most likely to be the E. coli, then the enterococci, streptococci, anaerobe, streptococci, as we said, Clostridium welchi, Bacteroides, and Bacteroides is most likely to be perforated. Pseudoappendicitis, this is an entity when we have a Yersinia infection. If you remember, Yersinia infection present with right iliac fossa pain, and this is often associated with Crohn's disease. The pathogenesis. About the pathogenesis, we have to understand that we have different types of appendicitis. We have the obstructing type of appendicitis, we have non-obstructing type, we have mucocele, we have perforation of the appendicitis, and the pathogenesis is how does this entity, how we can finally reach this entity. For example, if we are talking about non-obstructive appendicitis, it's actually inflammation of the mucous membrane with secondary infection with either viral or bacterial, and this finally will be either resolution, fibrosis, or recurrent appendicitis, or lead to obstructive appendicitis. If we have obstruction, whatever the cause, fecalith, lymphoid hyperplasia, especially in children, pinworms and other worms, foreign body, carcinoma, Crohn's disease, so the mucus and inflammatory fluid will collect in the lumen. This will increase the intraluminal pressure, and this would lead to the ulceration, ischemia, bacterial translocation, and spread of this infection, and will cause finally acute obstructive appendicitis. And if this progress more, there will be thrombosis of the appendicular artery, ischemia, gangrene of the appendix, and perforation at the tip or the base, but it's the perforation actually at the antemesenteric border, and eventually it may lead to peritonitis, sepsis, and okay. After perforation, if perforation happens, so there will be localization. It's like the defense mechanism. By what? By the omentum and dilated ileum. Just concentrated that the greater omentum and the ileum get dilated, and so it surround this infection. If we have collection, so this is appendicular abscess. If no collection, so we have the greater omentum and we have the dilated ileum. This is what we call it the appendicular mass. What is the appendicular mass? It is appendicitis localized by the greater omentum and a dilated ileum. All these together are called the appendicular mass. Okay. Entity in the pathogenesis is when there is obstruction of the lumen of the appendix, but the inflammation subsided and so the fluid is collecting there. This will lead to what we call it the mucocele of the appendix. So we have non-obstructing acute appendicitis, we have obstructing appendicitis, we have appendicular abscess, we have appendicular mass, we have mucocele of the appendix. Some of you will ask, do we have a chronic appendicitis? Yes, we have. We will see later in this lecture. So this leads us to the type of appendicitis. Is similar to the pathogenesis. I know that pathogenesis for surgeon is not a lovely word. Okay, the type, we said acute non-obstructing appendicitis, catarrhal, mucosal appendicitis. It's inflammation of the mucous membrane occur with redness, hotness, etc. And the course of this, what will happen in acute non-obstructive, either resolution non-operatively, ulceration, fibrosis, separation, recurrent appendicitis called subacute appendicitis, or gangrene, or even peritonitis. And we have the acute obstructive appendicitis, as we already explained, and we have the recurrent appendicitis. This is when we have a partial obstruction or non-obstructing appendicitis, we will have recurrent symptoms of appendicitis. Subacute appendicitis, it's it's like the recurrent appendicitis with a milder symptoms. And the stump appendicitis, this is when we leave long tip of the remnant part of the appendix after appendectomy. This is actually commonly after laparoscopic appendectomy. Clinical feature. Okay. And clinically, we have to recognize that it is rare before the age of 2. It is more common in children and other age group, as we said in the second and third decades. We have pain as a clinical feature with high sensitivity, specificity. It is the earliest symptom. The pain actually starts as a visceral pain. It starts around the umbilicus, and then it moves when the appendix gets irritation or in contact with the parietal peritoneum and causes somatic pain. So it starts with visceral pain at the umbilicus and then somatic pain at the right iliac fossa due to the irritation of the parietal peritoneum. Okay, so this is called the migratory behavior of pain. Okay, we have vomiting with sensitivity and specificity about 50s, nausea and anorexia. You can see the sensitivity of anorexia is about 70. Some literature says that no appendix without anorexia. Okay, this is the Murphy triad where it describes when and what happened. Pain comes first, vomiting next, temperature last. This actually differentiated from gastroenteritis when vomiting comes first. Constipation, yes, maybe constipation, and sometimes maybe diarrhea. It's due to, especially if the appendix is in the pelvic location, posterior location. Tachycardia, halitosis is a feature. Urinary frequency, pictures of UTI, especially when the tip of the appendix gets attached to it gets in contact with the bladder and cause bladder irritation. Tenderness and rebound, tenderness at McBurney point. We will see where is McBurney point exactly. This is called the Blomberg sign. The rebound tenderness. This is rebound tenderness. Actually, when we press, if pain elected, this is tenderness. If we remove our hand and we elect pain while removing our hand, this is rebound tenderness or McBurney sign or Plainberg sign. These are typical for appendicitis. Rovsing sign, it's when, you can see here, it's when palpating the left iliac fossa, pain elected in the right iliac fossa. Other two main sign we have to know is the psoas sign, or called the hyperextension sign. You can see here we have hyperextension of the leg and we will elect pain. Other sign is the obturator sign. We have external rotation of the thigh, internal rotation of the leg, while the hip is flexed, and so we will elect pain. This is called the obturator sign. If we want to talk about the sign, we will not finish. There are more than actually hundreds or a lot of signs of appendicitis. So the matter is not to know all of them. Actually, it's just these are the most important signs, and we will see now how we can diagnose appendicitis according to Siriton classification system. Okay, we have Bladwing sign, we have Pastidi sign. Pastidi sign is actually when you inflate the rectum with air, so you will elect a pain in the right iliac fossa pain. It's for study, actually. It's for researchers, I think. PR, when you do PR for the rectum, you will elect pain in the right iliac fossa. One of the signs also nice to know is the hyperesthesia in Sheeran triangle. This is Sheeran triangle, actually. Umbilicus, symphysis pubis, anterior superior spine. We have, if we touch slightly this region, there will be hyperesthesia. Okay, this is just, they repeat the information. We said that appendicular mass, what causes appendicular mass? It's the appendix, it's the omentum, it is the dilated ileum. Okay, this is a review of some sign: Rovsing sign, Blomberg sign, release sign, rebound sign, all are the same. Psoas sign, obturator sign, Bladwing sign, Pastidi sign. Dunphy sign, it's when you cough, you elect pain in the right iliac fossa. A lot of signs. It's not for a special consideration. We said that in infancy it is rare, but if it comes, it has a high risk for perforation, 80% chance of perforation, and mortality is very high. So we proceed for appendectomy with a low threshold for conservative treatment. Acute appendicitis in children also. The problem here is localization will not present, so we will not have the typical sign we already talked about. So peritonitis can come early, and so early surgery is recommended. In elderly, it's similar like to the children. Gangrene and perforation is more common when we compare it to the classic patient, to the classic young patient. Localization is poor, and so peritonitis is early. The problem with elderly that we have a wide spectrum of differentiation. We cannot know this is diverticulitis, this is perforated cecal sigmoid tumor. So if we treat it conservatively, so please do not forget colonoscopy. In pregnancy, the incidence is about 1 every 2,000 pregnancies. Actually, it is the most common non-gynecological surgical emergency in pregnancy. It's more common in the first and second trimester. Okay, we know that the uterus actually push the appendix up, so we can have the sign and symptoms in their atypical location. So pain can be higher and more lateral. Okay, risk for premature labor is 15. Fatal death in early appendicitis is 5%. In perforated appendicitis, the risk is 30%. Okay. Actually, surgery is the treatment of choice in pregnancy. We do not wait until, or we do not try conservative method of a treatment in pregnancy. Here is a picture just summarizing the appendicitis in pregnancy. We said most common non-obstetric surgical disease in the abdomen during pregnancy. Actually, the risk for developing appendicitis in pregnancy is the same as the pregnant woman. The incidence is 1 to 2,000. We said that it occurs at any trimester, but a slight increase in the second trimester. Perforation is more common in the third trimester. Fetal mortality is 30 to 35 if we have appendiceal perforation. Clinical feature is the same. We have one of the signs for a pregnancy called Rupashka sign. Actually, Rupashka sign is Rupashka means by Russian language is t-shirt sign. Is just pulling the t-shirt and touching the t-shirt. The pregnant woman will shout of pain. This is have a high sensitivity for females. Okay, diagnosis ultrasound. Okay, and the treatment early appendectomy during all stages. Laparoscopy, yes, it's safe to proceed with laparoscopy, especially if you can in the third trimester. About the diagnosis, just I want to mention, okay. And one information I want to add in diagnosing appendicitis in pregnancy, yes, it's written here that ultrasound is helpful, but if we have doubt, if we are not sure of our diagnosis, we have low threshold to proceed for MRI. It as it is radiation free. So MRI sometimes is helpful in diagnosing appendicitis in pregnant woman. About the differential diagnosis of appendicitis, wide spectrum. Actually, this depends on the gender. Is it male, female? On the age, is it children, adult, elderly, etc. One of the differential diagnoses is perforated duodenal ulcer, as these are both are emergency, present with abdominal pain. We said appendicitis actually starts as umbilical pain, and in perforated duodenal ulcer, one of the scenario is when the leakage of fluid transfer through the right paracolic gutter and collect in the right iliac fossa. So it mimic free fluid in the appendicitis, rupture appendix, but actually it's perforated duo. This is what we call it Valentino syndrome. Other differential is acute cholecystitis, acute pancreatitis, right ureteric colic, acute typhlitis, and we said typhlitis is a common term for inflammation of the cecum, which is called typhlitis. Okay, bacterial enterocolitis, acute mesenteric lymphadenitis, especially in children, where we have children or children with upper respiratory tract infection, and now he's complaining of abdominal pain. If we investigate him, we will find multiple mesenteric lymph node. This will lead us to the diagnosis of acute mesenteric lymphadenitis. It is acute right lower quadrant abdominal pain associated with mesenteric lymph node enlargement and normal appendix. Okay, Yersinia enterocolitica is associated with the syndrome. Yersinia can cause acute mesenteric lymphadenitis, and the treatment is conservative. Of the differential also is right-sided acute pyelonephritis. Crohn's disease, we said that Crohn's disease, the most common location is the ileocecal region. In female pelvic inflammatory disease such as salpingopheritis, such as tubo-ovarian abscesses, etc. I'm not sure about my pronouncement, is it correct or not, but Mittelschmerz syndrome, it's where we have lower abdominal pain due to rupture of the follicular cyst in the middle cycle of female. This will mimic the picture of appendicitis. Meckel diverticulitis, well, this is Meckel actually. We know the Meckel is 2 feet from the ileocecal junction, and it can be infected and present as diverticulitis. So Meckel is one of the differential. Intussusception in children also is one of the differential. Worm infection also is one of the differential. Right-sided lobar pneumonia, it's more with the differential of acute cholecystitis, but it also can disturb us. This is an important also differential, is the testicular torsion, okay, and acute severe orchitis. Yes, it can present with lower abdominal pain and right iliac fossa pain. Sigmoid diverticulitis, especially in elderly. Yes, the sigmoid is in the left, but it can loop and can be redundant, so it will present as a right iliac fossa pain. Carcinoma of the cecum, especially in elderly. Rupture aortic aneurysm, and some rare conditions such as herpes. If you remember, herpes zoster can come in the dermatome 10 and 11 dorsal nerve, and so we will have hyperesthesia there. Okay, other differential is tuberculosis of the spine, multiple myeloma, osteopenic pain, all can mimic acute appendicitis. You can see here the wide spectrum of differential diagnosis, and this depends whether it's children, female or not. We actually discuss most of them. Okay, if we take care of the differential diagnosis in elderly, acute diverticulitis, carcinoma cecum, mesenteric ischemia, intestinal obstruction, aortic aneurysm leak, Crohn's disease, so it's a little bit difficult sometimes to diagnose acute appendicitis. The sequence, what will happen if we leave acute appendicitis not treated? Resorption. It will the mechanism, the defense mechanism will get rid of that, and everything will be okay. Relapse or recurrent, especially in partial obstruction or non-obstructing appendicitis. Appendicular mass, we said appendicular mass, it's the appendix, it's the dilated ileum, it's the omentum. Appendicular abscess, perforation with high mortality, it's about 30. The mortality with perforation is up to 30. Peritonitis, septicemia. Portal paema. Portal paema, it's when the infection with the venous drainage to the portal vein and get to the liver, actually as in portal paema, and we will have multiple liver abscesses if not treated. Intestinal obstruction due to obstructive ileus, inflammatory adhesion can present. Okay, about the investigation, how we can investigate the appendix. Okay. And what investigation we need to support our diagnosis? First of all, CBC, complete blood count. We will see a rise in the white PCs and neutrophil shift. Ultrasound will help us in confirming the diagnosis and in ruling out. It's a matter of sensitivity and specificity. Sensitivity is the ability to detect the disease, and specificity, it's the ability to rule out the disease. So ultrasound can help us in detecting the disease, and also it can rule out other conditions like ureteric stone, pancreatitis, and gynecological causes such as ovarian cyst, ectopic pregnancy, and etc. Okay, laparoscopy, if we proceed for laparoscopy, it's the best for diagnosing the appendicitis. Okay, the sonography criteria for appendicitis carries a high specificity and this includes non-compressible. It's non-compressible tube-like structure or appendix with the AP diameter more than 6 millimeter, or wall of the appendix more than 2 millimeter. The wall of the appendix will be more than 2 millimeter. Appendicolith we can see in the sonography, in the ultrasound. Also, the submucosal continuity will be disrupted. Periappendicular fluid also is diagnostic for appendicitis. But this actually doesn't reach the 100% or even the 90% sensitivity. A CT scan can help us, especially in old age and young children. We said when we say pregnant, we think of MRI. Okay, contrast is helpful in elderly patient. I think that in elderly patient there is a wide spectrum of differential, including cancer. So we proceed for CT. Of these finding on the CT, dilated appendix, dilated lumen, thickened wall, non-filling of the lumen by contrast of air, periappendicular fluid, presence of abscesses, mass, cancers. Okay. Dirty fat around the appendix and mesoappendix. This is a very helpful sign. Appendicolith, appendicolith, we can find it also. You can see here that CT scan has improved the diagnostic accuracy in individual. However, the rate of misdiagnosing of appendicitis remain constant. Okay, C-reactive protein is not a specific nor sensitive, but it's actually elevated, especially in the acute phase. A leukocyte imaging, it's actually a type of nuclear medicine where you can find that the leukocyte is aggregated in the right iliac fossa. As we said, MRI is helpful in pregnancy. X-ray, we can find some sign of appendicitis. Of these signs are lumbar scoliosis. It's like due to pain and spasm of the psoas muscle. Ficcolith, obliteration. Okay, what else we can find in the X-ray? We can see pneumoperitoneum, but this is rare. If there is perforation and so air accumulation, this is extremely rare in appendicitis. And we can in X-ray find the sign of intestinal obstruction if we have obstruction. Okay, it can help us in ruling out perforated DU, air under diaphragm. Okay, I know that. Air can be also presented with perforated appendicitis, but with a less frequency. Scoring system. Actually, this scoring system will help us to guide our treatment plan. It's like a constellation. It's we put all parameters together and try to help us. And of these are the Alvarado scoring system. Sorry, and there is modified Alvarado, by the way, we will see. And Alvarado is score out of 10. You can see that only tenderness in the right iliac fossa takes 2, and leukocytosis more than 10,000 takes 2. Other parameters such as migratory pain, anorexia, nausea and vomiting, tenderness in the right iliac fossa 2, rebound tenderness, elevated temperature, leukocytosis 2, and shift of neutrophil. These will make a score of 10. If we want to analyze it, we see that if it is less than 5, so we are not sure that this is appendix. If it's between 5 and 6, compatible. If it is between 6 and 9, probable. If it's more than 9, it's confirmed. Some scoring systems help us, especially when we analyze them, when to do imaging. Of these scoring system, important score system, this is first of all the Alvarado. You can see, I think they are abbreviated in the word Mantrils. Okay, other important scoring system is the appendicitis inflammatory response score. You can see here vomiting takes 1, pain in the right lower quadrant +1, no rule for migratory pain, rebound tenderness, if it is light, medium, strong, 1, 2, 3, body temperature more than 38.5 +1, polymorphonuclear depends on the shift, more than 85 takes 2, less than that takes 1, white blood cells more than or between 10 to 14 1 more than 15 is 2. C-reactive protein here play roles in appendicitis inflammatory response score. So C-reactive protein, if it is between 10 to 15, it is 1. More than 50, it is plus 2. You can analyze it between 0 and 4, it is low. Between 5 and 8, it is intermediate, and between 9 and 12 it's high. Here intermediate will help us. So if we have intermediate appendicitis inflammatory response score, we can do further in hospital investigations and observations and diagnostic images. There are many scoring system. We said the most important already. We said that the modified Alvarado score, actually the shift to the left is removed from it. Many other scoring system such as Repasa scoring system 15 parameters and Anderson scoring system 8 parameters. It's not mandatory actually to know all of them. Treatment. Now we will talk a little bit, because this is a classic surgery, we will talk a little bit about the operative technique for appendicitis. Yes, it's not that simple. Many questions appear here. When to do appendectomy? Is it emergency? Is it picking the patient from the emergency department to the theater, or it is urgent, waiting until available theater, or until the next operating list? So many questions appear here. We will discuss everything and we will try to deliver the information simply. First of all, the classic treatment, appendectomy. We have multiple approach or skin approaches. Of them, the most classic, the most popular is the gridiron incision, also known the McBurney incision, also known the, I think, MacArthur incision. These are the line between the junction of the line between the umbilicus and the anterior superior iliac spine. The 1/3 to 2/3, 1/3 and 2/3 from umbilicus, 1/3 from the anterior superior iliac spine and 2/3 from the umbilicus. The junction here, if we draw a line that is perpendicular to this line, we will have the McBurney incision or the McBurney point. There are other incisions, I think it's written here, you can see. Let's zoom in a little bit. Sorry. How we can do zoom in? Yeah. Okay, here you can see this is the McBurney. It's like a perpendicular to the line drawn. We have the modified McBurney, or known as the Langer's incision or Lance incision. It's less perpendicular, more transverse, not completely transverse. It's cosmetically acceptable more. Okay, we have, if it's difficult to reach the appendix, we can do extension either upward and laterally. This is called the Rutherford Morrison extension, or the inward medially, and this is Fowler wire extension. And if it is transverse completely, it is Rocky Davis incision. We can do lower midline incision, especially in elderly, where is the diagnosis is not in doubt, and we can find a tumor or something like this. We found until we reach the appendix, we after the skin find the superficial fascia. This is the chamfer fascia and scarpace fascia. A little bit below we find the external oblique aponeurosis. A little below we have the internal oblique muscle, the transverse abdominis muscle. Then we reach the peritoneum, the parietal and visceral peritoneum, and we said that we find the cecum after we track the Taenia coli. When they join together, there will be the base of the appendix. The ileocecal junction actually is 2 centimeter above and medial. Okay, if we are talking about the open approach, open appendectomy, so this is how the appendix will look like in an open approach. This is not Babcock, in which we hold the appendix. This is the mesoappendix, and inside it, the appendicular artery. We actually, after identification of the base, you can see here, this is the tenii, this is 1, this is 3. We found the base, we track it, and we ligate the appendicular artery. In some cases, it can be very small or thrombosed, so cauterization is enough because of the thrombosis, or it's extremely vanished. Okay, then after ligation, we crush the base of the appendix and we transfix the base of the appendix. Transfix means taking a stitch through the appendix and ligator around it, right and left, until we. Some literature says that we do a circular a stitch around the cecum, around the base of the appendix, and so the appendix base is buried inside the cecum. This is not mandatory. So here you can see the mesoappendix and appendicular artery is ligated, and the base of appendix is crushed with artery forceps and transfixed with vicryl. Okay, these are the steps. Okay, here is the incision, our incision. This looks like a McBurney incision. Okay, and mesoappendix. Here you can see they try to control the artery and ligate the artery, appendicular artery. They ligate it. Transfixation, here we transfix the base, and some literature says that the stump should be not longer than 3 millimeter. Here they ligate and cut the appendix and remove it up. Some literature says that we have to puride or invest the stump in the cecum. This is not mandatory. Here some review about the complication we already discussed them. Paralytic ileus, of course, in the open appendectomy manipulation, so paralytic ileus is more common in the open appendectomy. Reactionary hemorrhage, this is when there is a clot and after 2-3 days the clot is dissolved, so this is called the reactionary hemorrhage due to slipping of ligator, or when the ligation or the clip we put or the vicryl we transfix slipped out, so can on the artery can reactionary hemorrhage present. Reactionary hemorrhage different from secondary hemorrhage and primary hemorrhage. Actually, there is different. This is called reactionary hemorrhage. Residual abscesses can be found. Pylophlebitis, portal pain, we already discussed when the infection travel along the portal vein and reach to the liver and can develop to liver abscesses. Adhesion as a late complication. Inguinal hernia due to the injury to the ilioinguinal nerve. Sepsis depends on complicated or not complicated appendicitis. If it's uncomplicated, the risk of surgical site infection is 5. If it's complicated, it reaches to 20-25. Fecal fistula, if we have the stump blow out, an intercutaneous fistula will develop. Respiratory problem and DVTs can develop as post-operative complication. Here they talk about the portal paema, we already discussed. Okay, now let's move to an important topic, actually, and it's not easy, the topic, it's a difficult topic. It's when we deal with appendicitis, 3 questions appear. First of all, when to do appendectomy? Should we do it directly once we diagnose the patient? This is what we call it emergent appendectomy, or we have time until we do our investigations and laboratory testing and we proceed to appendectomy in the next available theater in the next day until our specialist or our senior resident investigate it. This is called urgent appendectomy. The next question, should we proceed to appendectomy in all patients, or we can try conservative management? And the third question, if we proceed to conservative treatment and the symptoms subsided, should we do interval appendectomy? Interval appendectomy means that we treat the patient conservatively, the symptoms subsided, and after 2 weeks, 1 month, 2 months, we proceed for appendectomy. And actually, the literature is conflicting and controversial results appear, and no classic teaching information could be delivered. But I will try to make it simply for you. About the first question, is it urgent versus emergent? The first question should appear here. Are we talking about complicated or uncomplicated appendicitis? Let's first talk about the uncomplicated appendicitis. Uncomplicated appendicitis means appendix, pain, localized sign of infection. So here we can traditionally in the past, the appendix was thought, regardless complicated or uncomplicated, was thought to be an emergent procedure. Once we diagnose, we hurry up to the theater. But with the development of surgery and medicine, and with some scenarios that takes hours until investigation is completed, whether either radiological or laboratory investigations, we compare the urgent approach and the emergent approach. We compared them together, and we found that there is no differences in form of, for example, surgical site infection. They were similar in form of intra-abdominal abscesses development, in form of conversion to open procedure, in the operative time we need. The final information we can deliver that emergent versus urgent operation for uncomplicated appendicitis is dependent on each institution and surgeon. Institution without available operating room and staff may consider performing appendectomy in an urgent fashion. So we can wait until tomorrow morning, until next, this is in uncomplicated appendicitis, to the next operating theater, available operating theater. And we notice from the studies that the perforation is not associated with the length of in-hospital stay. No, most of the perforation present to the hospital already perforated. So in-hospital delay in surgery doesn't affect the risk of perforation. This is the first question. Second question, should we proceed to conservative or operative treatment? We said already we deal with uncomplicated. If it is complicated, we have two scenarios. The complication is contained or not contained. Not contained means we have sign of sepsis, we have peritonitis, general peritonitis. No question, we have patient with rigid abdomen. This is an emergency. We should immediately go to the surgery after resuscitation. But if we have complicated appendicitis with contained abscesses or phlegmons, here it's a little bit hard to deal with. We can proceed with conservative treatment. The summary of this: if we have complicated appendicitis, If there is sign of systematic infection, generalized peritonitis, proceed to surgery. If it is contained, the patient have phlegmon or have an abscess that is contained, we can try conservative management. Conservative management, by the way, can be IV fluid alone, or can be percutaneous drainage, or can be antibiotic and IV fluid, whatever. But we can try conservative treatment in patient with complicated appendicitis that is contained. We are not talking about patient who present with peritonitis, with sepsis, who should immediately go to the resuscitation. Another also here, just they highlight about who are more likely to present with complicated appendicitis. These are children less than 5 years. These are patients who are older than 65 years old. They present with another consideration about the operative treatment. We should proceed to operation, to appendectomy, not to conservative treatment. These are the pediatric age group. We should proceed because of the risk of perforation is high and the lack of systematic sign of perforation, and hard to detect the perforation clinically. And the female, especially female, either female in the childbearing period, or in female or in pregnant woman, we should have a low threshold for operative treatment, not conservative treatment. Okay, we said. Okay, what else we can add? You can see here actually the rule of non-operative treatment of uncomplicated appendicitis remains controversial. Currently appendectomy, okay, it's not important. Okay, interval appendectomy. Interval appendectomy, as we said, we treat the patient conservatively. Now we proceed to interval appendectomy, and the question appears here. First of all, after treating the patient conservatively, what is the chance of developing the sign and symptoms of appendicitis again? The answer is very low. Second question, should we fear of the risk of malignancy or perforation and proceed to the appendectomy and interval appendectomy? After many studies and after analyzing of multiple studies, they found that interval appendectomy is not recommended in the classic patient. No interval appendectomies, as the risk of developing appendicitis again is very low, and the risk of malignancy is very low to proceed for appendectomy as a biopsy. And the best approach is to do the following. You proceed with conservative management in patient with complicated contained appendicitis. So proceed to investigation, and these are closed clinical follow-up, history, full history, signs, symptoms, colonoscopy. All these should be done rather than interval appendectomy. Please note, in children, no conservative treatment. In children, we advise early appendectomy. The question is not urgent versus emergent. The question is operative treatment. Yes, the answer is operative treatment in children. I can't find the information here, I think. Here. In the pediatric literature, there is a superiority, where is it? Conclude that immediate surgical treatment was superior to conservative treatment with interval appendectomy. This is if we are talking about children. Okay, I hope we delivered the answer. Let's summarize it again. Urgent versus emergent.
doesn't matter. You can proceed for urgent, for uncomplicated appendicitis. Operative versus non-operative. If the patient have sepsis, rigidity, generalized peritonitis, proceed for urgent surgery. If the patient has contained, complicated appendicitis, you can try conservative management. But please complete your investigations. Of them is the colonoscopy, for example. Please, no conservative with children. Please, low threshold for surgery in female in childbearing age and in a pregnant patient. No interval appendectomy is not advised. That's all. Okay, let's proceed to the next topic we want to talk about. And I think this is some troubles in appendectomies. For example, I think we already discussed it. During surgery, if the appendix is found to be normal, what to do? We diagnosed the patient with appendicitis. We opened, but the appendix grossly looks normal. Yes, I know that. Macroscopically, you cannot conclude that 100% it's normal. But it's look like a normal. You should look for macular diverticulum, just to track the ileum. You should look for sign of Crohn's disease, signs for ovaries or pelvic causes. If it's in female and you find a normal appendix, you can call the obstetrician to help you. Appendicular tumor, we will discuss it later on, but if it is in the tip, appendectomy is sufficient. Carcinoid, we will discuss it a little few minutes in the next few minutes. But if it is in the base right, it could be carcinoid tumor. If it is in the base right hemicolectomy is done, we will discuss it. Absence of appendix, extremely rare, and please call your senior before you conclude that there is no appendix. Okay, appendicular abscesses and pelvic abscesses can form malignancy. Okay, if we find malignancy at the cecum at the time of the operation, so on-table right hemicolectomy should be done. If Crohn's disease is identified during surgery, appendectomy can be done if it's normal. If the appendix is involved, leave it for conservative because it may not heal and can develop fistula. Okay, another entity is what we call the incidental appendectomy. Incidental appendectomy, this is actually here, removal of a normal appendix is done at a laparotomy for another condition. We do appendectomy, but the operation was done for appendicitis. There are 4 or 5 scenarios and such we do incidental appendectomy. And the first scenario is when the diagnosis is vague. We have vague abdominal pain and we proceed. We found appendectomy, we do not find any other causes, so we proceed to incidental appendectomy. Other scenario is Munchausen syndrome. Munchausen syndrome, actually, it's a psychological explanation. It's when there is an abdominal pain and when the appendectomy is done, even it's normal, the pain is relieved. The third indication is the LAD procedure. The LAD procedure, we discuss it in the pediatric surgery lecture. It's after correction the malrotation, so the cecum will be in the left upper quadrant, and so in order not to confuse about the diagnosis in the future, of course, a patient with left upper quadrant pain, you will not suspect an appendicitis. So an incidental appendectomy is done during LAD procedure. Another scenario is when we do colonic lavage, on-table colonic lavage, calls Dodd-Lyes lavage. You can see here it's entering through appendicostomy. They do colonic lavage. Here appendectomy. is indicated as incidental appendectomy. We do not do incidental appendectomy or appendectomy in patient with Crohn's disease in the acute phase if we know that the patient have Crohn's disease, or post radiation, or in immunosuppression, or aura to iliac graft. Some of you will ask, Crohn's disease, we said that if Crohn's disease and normal appendix, we remove it. This is when we do not know that the patient have Crohn's disease. If we know that the patient have Crohn's disease, we do not proceed to appendectomy in the acute phase. But if we do not know, we enter the abdomen, we found feature of Crohn's disease, and the appendix is normal, remove it. Okay, another scenario is disabled patient who cannot describe symptoms or react normally to the abdominal pain. Another indication also for appendectomy is children who are about to undergo certain type of chemotherapy. And the last indication is these people who travel to remote area where the medical care is insufficient, where there is no medical care. Okay. This is not okay. Okay, here's some miscellaneous, some random information. For example, we said that the appendicitis is under the title, remember, it's more common in white, it's more common in young male than in female, it's more common in Western diet, more likely to affect individual between the 10 to 20, okay, between 10 to 30s, okay. We said that perforation most likely to develop before patient reach the hospital, okay. We said we have two types, non-obstructive type and obstructive type. Gangrene, perforation, peritonitis is rare in non-obstructive type, but recurrent appendicitis is common in non-obstructive type. Pneumoperitoneum is not common in patient with perforated, except it's theoretically acceptable. The lumen of the bowel is opened already, but it's rare. Appendicular artery is an end artery. There is no collaterals. There is no anastomosis, so thrombosis and gangrene and perforation more likely to develop. Okay. What else we talked about the diarrhea. This is difficult. Okay, we said that subhepatic appendix is difficult to remove it through the McBurney incision. You can proceed to Rutherford extension. Okay. We said about the pain location in a pregnant woman, it will be displaced up. And we said that it's the most common emergent non-gynecological surgery in a pregnancy. We also said that the incidence of fetal loss is 5% without perforation. If there is perforation, so it is not 20 but 30, even 30. So our threshold for surgery is low. We proceed for surgery in pregnant patient, if we have confirmed diagnosis, of course. Okay. Surgery in obese patient, and even diagnosis is difficult. It's rare before age of 2, but if it is present before age of 2, so perforation and peritonitis is higher than the classic age group, and so early appendectomy is advised in these patients. Negative appendectomy rate, it's about 30-20, depends on which institute, which country you are reviewing your study. Here is about McBurney described the first clinical. This is Amayan who do the first appendectomy. We said about situs inversus, it will be in the left. Okay. Here, chronic appendicitis, it's this term was not used in the past. Now it's used to describe a few attacks of recurrent appendicitis, especially in non-obstructing type, will lead to chronic appendicitis. Okay. Perforation rate is 25 in general population. In children and elderly, it's up to 40, up to 50. It's higher in children and elderly. Okay. The mortality is very low, less than 1. Morbidity and complication is more after perforated appendicitis. Surgical site infection for uncomplicated, it's 5%. For perforated appendicitis is 20%. We said that in children with appendicitis, there is poor localization. The omentum is not well developed to localize the inflammatory process, and peritonitis is common. So conservative therapy should be avoided. We should proceed to what we call it early appendectomy. We said appendicular mass. This is an important appendicular mass. This is when we talk about what we call it the complicated and contained. Appendicular mass is initially treated with Ochsner-Scheren regimen. I hope the pronouncement is correct. Here is after 6-week interval appendectomy is done. This is actually extremely controversial. This is not true, but this is because of I reviewed from many literatures. Okay. Risk factor for perforation. These are children, old age, laxative abuse, fecolith, diabetic patient, immunosuppressive patient, pelvic appendix. These have a risk for perforation. Okay. We said incidence of removal of normal appendix, you can see. We said 20, it's now 30, it's 20, 30, depends on the institute. Stump appendicitis, we talked about it, it's more common in laparoscopic surgery. It's when the stump gets infected. It's a very rare actually. Okay, this is the appendicular mass. When we talk about the appendicular mass, just remember when we reviewed the how to deal conservative or operatively, we said that complicated, contained, actually appendicular mass. These we proceed with conservative management. We said conservative management, but do not do interval appendectomy. Please go further with your investigations, with colonoscopy, with CT, whatever, laboratory, tumor markers, whatever depends on the history and physical exam. So, appendicular mass or periappendicular fragment. What's appendicular mass? Actually, it is the inflamed appendix. Here it is. It's the inflamed appendix plus the greater omentum plus the edematous cecum plus the parietal peritoneum plus the dilated ileum. These all called the appendicular mass. Okay, it is well localized by the omentum. Localized mean good mechanism of defense happened. It doesn't move with respiration here. No movement with respiration. Not mobile. Okay. Differential diagnosis. If we have appendicular mass, we have carcinoma cecum, cecal tumor, Crohn's disease, ovarian diseases, twisted ovarian cyst, actinomycosis, mesenteric lymphadenitis, ruptured ectopic pregnancy, ileocecal tuberculosis. So the investigations, the usual investigations of them, you can proceed to CT scan, ultrasound, CPC, the total blood count, the total white BC count will be increased. The treatment, we said conservative, it's called the Ocean-Sharon regimen. Again, I hope the pronouncement is correct. Okay, nature has already localized. Okay, we proceed for, this is the appendicular mass. You can see it is a lot of things together. It's the dilated ileum, the greater omentum, appendix, cecum, all of them. Okay, what is the conservative treatment? It can be antibiotic, IV fluid, analgesia, angitube, gastric acid suppression, percutaneous drainage, whatever. These are called conservative management. 90% of patients will respond to the conservative management. This is not true. This is actually from one of my literatures. Patient is discharged and advised to come for interval appendectomy after 6 weeks. This is old recommendation actually. Now we advise to proceed further with your investigations. It's not mandatory to do interval appendectomy. Some contraindication to conservative treatment or Ocean-Sharon regimen, when we should stop our conservative management and proceed to the surgical management, when we are not sure about our diagnosis, when the diagnosis is in doubt. In children and elderly, excellent. In gangrenous appendicitis, we said in patient with complicated generalized peritonitis, sign of sepsis, no way, proceed for appendectomy. In patient with diffuse peritonitis, here criteria to discontinue. Patient become more toxic, more tachycardiac, fever, persistent vomiting, increased of spread of abdominal pain. Abdominal pain is increasing, the mass is increasing in size. There is evidence of abscesses that is increasing. In this patient, we should discontinue. Actually, here the management of appendicular mass is what we already said. Appendicular abscess. Okay, and the appendicular abscess, it's actually either initially developed after acute appendicitis attack, or if there is appendicular mass and separation in an already formed appendicular mass. Okay, here they reviewed the location. It could be most often due to retrocecal appendicitis, but this is not mandatory. The clinical features of abscesses: fever, toxicity, tenderness, etc. The treatment here with minimally invasive surgery with CT guided drainage, with ultrasound guided drainage, and after the symptoms subsided, we proceed further with our investigations. It's not mandatory to proceed for surgery, for incision and drainage, and it's not necessary to do appendectomy. We proceed with our investigations in a form of colonoscopy, in a form of tumor markers, whatever. Actually depends on each individual scenarios. Okay, fecal fistula. Actually, fistula happens when the stump that we closed in the appendix using a vicryl or a clip, whatever, blow out or slipped, if we are talking about clips. So we have a fistula. We have first of all wound infection, then develop to enterocutaneous fistula. Another scenario is when when proceeding with appendectomy in patient with appendicular mass. We said we prefer to proceed with conservative management in appendicular mass. If we proceed for appendectomy, the risk for fistula, enterocutaneous or fecal fistula to develop is more likely. It's when we proceed to appendectomy, Crohn's disease, when there is distal obstruction, when there is cancer, when there is ileocecal tuberculosis, actinomycosis. So these are risks for developing fistula. The features: foul smelling discharge. Okay. And feature of infection: skin excoriation, feature suggestive of the causes. Investigations, actually this you can see a connection between the bowel and the skin. This is a fistulogram, CT fistulogram. Okay. The treatment of the fistula, this is enterocutaneous fistula. Actually, this is a different entity, and talking about how to deal with fistula is have many details, but actually fistula are classified to high output, low output. The more distal the fistula, I mean in the GI system, it's more likely to be low output, it's more likely to respond to conservative management. Conservative management can be in a ladder form, in a step form. Conservative management in a form of IV fluid MPO, or IV fluid alone. Then we suppress the gastric secretion. We can use octreotide, somatostatin analog. Then we can use TPN, total parenteral nutrition. So it will heal alone. But of course, you have to rule out the causes of fistula. I think they are abbreviated in the word friends, and one of them is distal obstruction. If there is distal obstruction, it will not heal. Okay, we said the treatment is conservative, but if the conservative treatment failed, we proceed for surgery. I do not actually highlight on the or concentrate on the period because this is different from literature to another. Here, if persist even after 6 weeks, proceed for surgery. Surgery in a form of ileocecal resection and anastomosis. This is not true absolutely or 100% because we can treat fistula up to 3, 4, 5 months. It depends on individual cases, on whether it is high output, low output, the clinical impact on the impact of the stoma on the patient life. So we try first conservative management. If failed, we proceed to surgery. An important topic in the appendix we have to review is the mucocele of the appendix and pseudomyxoma peritoniae. Okay, mucocele of the appendix. Actually, it is accumulation of mucoid material in the appendix. It will look like a dilated, enlarged appendix like that. You cannot predict it preoperatively despite the imaging. 4 processes to develop appendiceal mucocele. This is the retention cyst. It could be due to retention cyst or mucosal hyperplasia, cyst adenoma, or cyst adenocarcinoma. The problem in mucocele of the appendix is that it could be neoplastic or non-neoplastic, benign or malignant, and this is challenging for the surgeon. Here you can see we expect that this is the appendix, but you cannot 100% confirm that it's appendix. Plus the biopsy is contraindicated as rupture can lead to pseudomyxoma peritoniae. So no rule for biopsy, no rule for frozen suction, intraoperative biopsy. Okay, as we said, the feature, it's actually like a subacute appendicitis or appendicitis with a grossly enlarged appendix. Okay, it can be infected and lead to empyema, not just mucus, but an empyema of the appendix. The problem is with the rupture of the mucocele, and even intraoperative rupture. This will lead to pseudomyxoma peritoniae. This is a bad entity, we will see. Actually, we said it could be benign and malignant. The benign, more likely, if pseudomyxoma peritoniae develop, the pseudomyxoma peritoniae more likely to be localized, whereas malignant more likely to be generalized pseudomyxoma peritoniae. Okay, most likely to be from the appendix, but can be due to mucinous carcinoma of the ovaries. Okay. Here If a mucocele of the appendix is also caused by adenocarcinoma, mucinous adenocarcinoma, so right hemicolectomy. But how we can know intraoperative? We cannot. This is a second surgery. This will be a second surgery. The clinical feature of mucocele of the appendix is similar to appendicitis, but in a milder form, in a subacute form. Colicky pain in the right iliac fossa, tenderness, clinical presentation, okay. Investigations, you can do ultrasound or CT. The biopsy is contraindicated. Not the surgical biopsy. The surgical biopsy is when we proceed for appendectomy, but preoperative biopsy is contraindicated. The treatment is appendectomy. Proceed for appendectomy. This is your rule. Okay, what you need to do if you suspect a mucocele. We said preoperatively it's hard to know, but intraoperative you suspected the mucocele, it's enlarged, filled with gelatinous or semi-fluid material, so you have to keep the appendix intact and prevent perforation. Sometimes if you are dealing with laparoscopic or approaching with laparoscopic appendectomy, you can convert it to open in order not to rupture the appendix, or you can use basket or retriever in the abdomen by laparoscopic approach. So, intact mucocele, no risk for pseudomyxoma. The problem is with pseudomyxoma peritonei. We do not want pseudomyxoma to develop. Here they advise if to convert to open laparotomy. Okay, it's advised, but with a trained, skilled surgeon, he can continue with laparoscopy, but he can use certain technique to extract the appendix in a bag. Okay, what's else? How should we proceed? We said with appendectomy. Okay, intraoperative and in the initial surgery, we have to do what we should proceed for appendectomy, but if we suspect mucocele, we should do wide resection of the appendix, and this include any suspicious lymph node and collection of collection of fluid for cytological examination. Further, it's not your rule actually. Intraoperative mucocele of the appendix, hard to know preoperatively. So what can I do? Appendectomy, wide resection of the mesoappendix, removal of any suspicious lymph node, taking fluid for cytology, and close. Okay, next, right hemicolectomy or ileocecotomy is reserved for patient with positive margin. If we have positive margin at the base of the appendix or positive periappendicular lymph node. If we did our first surgery, we said that we have to do wide local excision of the mesoappendix and take any suspicious lymph node. If the lymph node is positive or the base is involved, so then we proceed to right hemicolectomy. It's not from the initial surgery. Okay. Any other thing we can add it more than the right hemicolectomy? Yes. Here they said an aggressive approach for ruptured appendiceal neoplasm, if we have already ruptured and it or positive margin or positive lymph node, we can proceed for we can refer the patient to special center for exploration and hyperthermic intraoperative chemotherapy. This is actually a second operation. Not only right hemicolectomy, but also right hemicolectomy plus hyperthermic intraperitoneal chemotherapy. Here you can see right hemicolectomy is reserved for patient with positive margin at the base and or positive lymph node. The treatment, the classic treatment, I proceed for patient with appendicitis. I suspect mucocele of the appendix intraoperative. Please do not rupture the appendix. How, I don't know. Either convert it to open, call your senior, but the classic operation, appendectomy, wide resection of the mesoappendix, any suspicious lymph node, please remove them. Take take fluid, if there is fluid, take it for cytological examination. Okay, that's all. We said the second step to check the histopathology. If positive lymph node, if positive lymph node, positive margin, positive culture. If we have rupture, we proceed for right hemicolectomy and chemotherapy, hyperemic intraperitoneal chemotherapy, but this is in a specialized center. We fear of pseudomyxoma peritonitis when rupture of the appendix happened. It's more likely if there is malignant. We say we have malignant and non-malignant. It's more likely with malignant type. It's more likely with large mucocele, more than 2 centimeter. Pseudomyxoma peritonitis can develop. What does pseudomyxoma peritonitis mean? It's actually a diffuse collection of gelatinous fluid in the abdomen called the jelly belly, associated with mucinous implant and peritoneum. You can see here, this is how it's look like. This is pseudomyxoma peritonitis. Actually, its surgery is difficult, and this is done by trained, skilled surgeon. Okay, let's go in the details of the pseudomyxoma peritonitis. Okay, it's more common in female, more likely to be due to the appendix. The second cause is the ovaries. Okay, the classification of pseudomyxoma peritonitis, either the appendix or the implants, they are classified to low-grade appendiceal mucinous neoplasm or high-grade appendiceal mucinous neoplasm, and also the implant, the same, low-grade and high-grade. Here, the implantation of the pseudomyxoma peritonitis are classified to low-grade or high-grade pseudomyxoma peritonitis. Despite of the type, all can result in ascites and manifestation of vague abdominal pain, obstruction, intestinal obstruction. Not frequently can cause encasement of the ureter and causes hydronephrosis. Okay. What else we can? Okay. Pseudomyxoma peritonitis, in the past they thought that it's a benign procedure, a benign condition. Recently it's benign, behave like a malignant, so they consider it a borderline malignant condition. Pseudomyxoma peritonitis, a bad entity, it carries a bad prognosis actually, despite the surgical treatment, we will see. We said that the symptoms are non-specific. These are abdominal pain, distension, mass, ureteral obstruction, venous obstruction. Okay. Recurrence rate, even after surgery, extremely high. 75% will have recurrence. The distant and the lymph node metastasis is uncommon. It's actually type of local invasion. Lymph node metastasis in pseudomyxoma and distant metastasis are uncommon. Actually, here I think the preoperative imaging can help us. You can see here in CT scan how pseudomyxoma peritonitis. Of course, with the combination of the history, you can figure that this is pseudomyxoma peritonitis in a patient who underwent appendectomy with positive histological findings, so it can be helpful. Okay, what else? The treatment is actually removing all what you can see. It's called R2, if we are talking about the macroscopic residual tumor, all what we can, it's actually delayed for a trained, skilled senior surgeon. It's not an easy surgery. As we said, the recurrence rate is high. It needs debulking. You can see all gross disease and omentum should be removed. One, if not done previously, appendectomy should be removed. 2, 3. Hysterectomy and bilateral salpingo-oophorectomy in female should be performed. 3. There is also 4. Let's survival. Okay, they actually compare between survival in R0 resection compared to R2 resection. And of course, R0 is better. R0, it's when you completely remove the tumor with no tumor cell within 1 millimeter of the resection margin. This is called microscopic resection. While R2, it's what we see, we remove only. But R0, it's guided by the histopathological reports. So R0, even microscopic deposit are removed, the survival will be better. So the more aggressive the resection histologically, the better the prognosis. 5-year survival, you can see it's very low. 5-year survival for mucinous appendiceal neoplasm is 30 patients. We have to proceed here for intraperitoneal hyperemic chemotherapy. It's a standard, we said, appendectomy, radical resection, omentectomy, first of all, here, debulking surgery. This is include removing the omentum. Any gross, any mucinous neoplasm, remove it. Omentum, remove it. Appendix, remove it. Salpingo-oophorectomy, remove it. Plus intraperitoneal hyperemic chemotherapy. This will be adjunct, will help the treatment, our treatment. Removal of any visible tumor called radical cytoreductive surgery. This is radical cytoreductive surgery. So the treatment of pseudomyxoma peritonei is cytoreductive surgery. It is removal of any gross. Of course, intraoperatively, you will not wait until frozen section will come back until you that the margin is far from the disease or not. So it's gross removal of the any implants, any mucoid, any jelly-like material, omentectomy, appendectomy, salpingo-oophorectomy, intraperitoneal chemotherapy. These are cytoreductive surgery plus intraperitoneal chemotherapy. Okay. Okay. If we have recurrence, investigate again and do surgery again. Here you can see chemotherapy, intraperitoneal chemotherapy in a form of cisplatin is beneficial. Poor prognosis. This is how it looks like. You can imagine you should remove all of these, any finding, any macroscopic finding, you have to remove it. The more aggressive the resection, the better survival. But I wonder how I can reach R0 resection. Microscopic negative, all things are removed, even in the histological reports. That's difficult. Okay. Pseudomyxoma peritonei is presently considered due to neoplasm adenocarcinoma. I said it's not important. The treatment, we said treatment is surgery, form of cytoreductive surgery plus intraperitoneal chemotherapy. Okay, let's talk briefly about the laparoscopic appendectomy. Okay, and about the laparoscopic appendectomy, it's now the gold standard method of treatment. We actually routinely, it should be done routinely, the laparoscopic appendectomy, but I know that this depends on the hospital itself, on the trust itself, the institution, the availability of instrument. Especially most of these surgeries are done at post after finishing the operating list. So many hospitals doesn't provide the sufficient instrument. Actually, as we said, it's the gold standard operation. It was first done at 1983 and become popular just after the laparoscopic cholecystostomy comes popular. This is because the incision for open appendectomy is small, but in general now the standard treatment for appendicitis is the laparoscopic appendectomy. Advantages is the advantages associated with the laparoscopic surgery, and these include plus in laparoscopic surgery we can visualize certain part that is difficult to visualize in open surgery, such as the pelvis in female. Of these advantages, the abdomen entirely is visualized. In female, we can assess the pelvis. The trauma is less, faster recovery. Okay, laparoscopic appendectomy is better when we have vague abdominal pain. We are not certain. It's type of diagnostic procedure. It's laparoscopy. If appendicitis is present, we proceed for laparoscopic appendectomy. Okay, and in patient with atypical pain, vague abdominal pain, prefer to proceed with laparoscopic appendectomy plus situs inversus. And in women, it's better. Subhepatic appendicitis. Okay. Disadvantage, we said the technical difficulties, the cost, and please consent every patient going to have laparoscopic appendectomy that it may be converted to open. The technique you can see here, the position of the surgeon. Here is the surgeon, here is the assistant, they are standing on the left, here is the appendix, here is the anesthesiologist, here may be the scrub nurse under general anesthesia. Okay, this is also not routine. We can proceed with high thoracic anesthesia, high spinal anesthesia, and proceed for intra-abdominal laparoscopic surgery. But under general anesthesia, a slight tilt to the left so that the bowel is far away from the site of work. Here is actually where I can insert my ports in laparoscopic appendectomy. Different, depends on the surgeon, but what is constant is we have an umbilical 10 millimeter working approach, our working ports. You can insert 5 millimeter on each side, or 5 millimeter trocar on the supraumbilical, suprapubic, and the left iliac fossa. It depends on the surgeon. No constant rule for that. But the constant is we have 10 millimeter to extract the appendix, and it's better to be in the umbilical side. Okay, pneumoperitoneum is created and the appendix is identified. Here is the what we call it the appendiceal critical view. We have the critical view of safety in lap cholecystectomy. If you remember, two structure and only two structure are entering the gallbladder. These are the cystic duct and cystic artery. We have also the critical view of safety in appendix, and this is first. If you imagine this is an o'clock, we have at 3 o'clock the tinea coli. This is called the tinea labria, the large tinea here of the cecum. We have at 6 o'clock the ilium. Here you can see this is the tinea labria. It's at 3 o'clock. Here is the cecum at 6 o'clock. And we retract the appendix to 10 o'clock. 3 o'clock the tinea labria or labria, I don't know. Oh, and 6 o'clock is the ilium. Here it is. Here it is. And the appendix is retracted to 10 o'clock. This is the appendiceal critical view of safety. The mesoappendix can be cauterized using bipolar or unipolar, and the appendix is removed preferably with a bag. We use a bag. Here it is, retriever bag. We fear of mucocele, cancer, implantation, bitter for infection, so we use a bag. Okay, what's else? Here how we can ligate the base of the appendix. We have what we call it the intracorporeal ligator. Here it is. Okay, when we close the umbilical port, actually this is also a matter of study. When to close the fascia of the wound created due to trocar insertion, and to remember any midline above 6 millimeter, any midline above 6 millimeter should be closed. The fascia should be closed. If it is not midline deviated right to left, I think above 1 centimeter should be closed. Here in this literature, this says umbilical port should be closed in 2 layers, while the other ports, the skin is enough. It's not mandatory if there is gangrenous or pressed abdomen to convert it to open. This depends on the skills of the surgeon. He may proceed with using a bag. This is how laparoscopic appendectomy looks like. Okay, one of the theories or of the practice is single incision appendectomy. When you insert just one trocar, this is a matter of a study. It's a less pain, better cosmetically, but it's not. There is no obvious advantage over the standard laparoscopic appendectomy with 3 incision or 3 trocars. One of them should be large, 10 or 12. Laparoscopic assisted appendectomy, it's when we use a hybrid procedure. We use laparoscope, but we remove the appendix. We said there, we remove it intracorporeal. Here we did intracorporeal resection or ligator. This is inside the abdomen. Sometime after we freed the appendix, we bring it outside the abdomen through one of the trocar incision, and this is called laparoscopic assisted appendectomy. You can see here it's laparoscopy, but eventually they bring the appendix. They do appendectomy as open procedure. The advantage is it's faster, actually, faster compared to the laparoscopic surgery. Okay, one of the theoretically, I think it's not extremely clinically significant, is what we call it the NOTS, the natural orifice transluminal endoscopic surgery. Just concentrate here. It's a type of surgery where they do not use a skin incision. They actually enter the abdomen through the natural orifices. What are the natural orifices? Mouth, upper GI, anus, vagina, no skin incision. And so theoretically, we can do appendectomy either through transgastrically or transvaginally. You can see here they enter transvaginal and then they remove the appendix. Actually, it's not my opinion. It's what's written. Also, it is just theoretically. It's the concept behind NOTS surgery. NOTS can be done for thyroidectomy also. Many surgeries can be done, but if we are talking about appendectomy, it's to avoid skin infection, because we will not have a skin incision. We will avoid hernias, but it is not extremely supported until now. It is investigational procedure. In the world, it's about 113 surgeries done. Of them, most of them was transvaginally, and 26 cases were transgastrically. Actually, you will have enterotomy. You will penetrate the stomach, so you have to. There will be an incision at the finally. So I don't see that it's extremely beneficial clinically. Okay, even here a study reviews that even patient wasn't so happy of this surgery. This is how the transvaginal approach. They enter the vagina to the abdomen, they proceed to the appendix, they remove it. No incision. Okay. Okay, here we finished our first part of this lecture. We reviewed the appendix, appendicitis, operative approaches, different operative approaches, timing, when to do conservative surgical treatment, etc. Now we move to the second part of our lecture, which is the appendiceal neoplasm. We will try to make it simple and brief. Okay. And now let's move to the second part of this lecture, and it's about appendiceal neoplasm. And actually here we have to remember that appendiceal neoplasm or tumors are rare. They are actually found after doing appendectomy and reviewing the histopathology. It's hard to predict cancer based on laboratory or clinical or imaging before the histopathological report declare that this is cancer. This is one. As a key concept or a general rule, we have 3 or 4 scenarios in appendiceal neoplasm. Of them is the adenocarcinoma, different subtype of them. The worst subtype is the single ring cell. Best prognosis is goblet cell. We have also mucinous adenocarcinoma, clear cell adenocarcinoma. Actually, if we have a tumor, adenocarcinoma of the appendix that is limited to the mucosa or submucosa, it's enough. In another word, it's T1 well differentiated. It's enough to do appendectomy. Otherwise, we proceed to right hemicolectomy. Okay, this is one. As we previously discussed, the mucosa of the appendix, and it may be benign or malignant, if we proceed for appendicitis and we found a mucocele or highly suspicious for mucocele, we should do appendectomy, wide resection of the mesoappendix, washing for cytology. We take any fluid for cytological exam, and what's else, biopsy of any suspicious lymph node, and we wait until the result comes back. If the result comes back and confirm that we have lymph node invasion, lymph node involvement, or the margin is not clear, so we proceed to cytoreductive surgery. And we said cytoreductive surgery, this is a second surgery done by a senior surgeon. It takes a long time, it's hard, it includes removal of any suspicious lesion, it includes intraoperative chemotherapy, it includes R0 resection if possible. So it's also involved hysterectomy with removal of the ovaries and tubes. So this is a second stage after we did our first surgery, which include what we said, the appendectomy, wide resection of the mesoappendix, and cytology and any lymph node involvement. This is about the mucocele of the appendix. Actually, you cannot know intraoperative this is benign or malignant. You can predict based on the behavior if there is, for example, widespread of peritoneal implants. So mostly it's malignant. The size, sometimes they says more than 2 centimeters is possibly to be malignant, but these are not cutoff numbers. If we are talking about the neuroendocrine tumor, so a cutoff number here exists actually. If we have a neuroendocrine tumor that is smaller than 2 centimeters, so appendectomy is enough. If we have a neuroendocrine tumor that is more than 2 centimeters or plus high risk feature, what are they? These include the incomplete resection based on the pathological exam, the location is in the base of the appendix, Ki-67, this is actually proliferative marker for malignant cell, more than 2%, lymphovascular or pre-neural invasion, mesoappendix is involved, so we should proceed to right hemicolectomy. Okay, here they just discuss the differential diagnosis, and for the fourth or fifth time I said it's hard to detect on imaging that this is cancer. It's a histopathological exam, so the differential diagnosis of appendiceal mass or thickening is, for example, appendiceal mucinous neoplasm. It can be adenocarcinoma, melanoma, leiomyoma, lipoma, fibroma, neuroma, lymphangioma, metastatic spread, especially from the ovaries, cecal tumor. It could be phlegm, simply. These are the neoplastic. Non-neoplastic, it could be Crohn's disease or neutropenic enterocolitis, typhlitis, tuberculosis, actinomyosis. It could be mesenteric cyst, non-steroidal anti-inflammatory induced damage, and appendicitis. It's just an appendicular mass, not so. Again, appropriate diagnosis often after appendectomy. Preoperative biopsy, no rule for preoperative biopsy, and no rule for intraoperative frozen section. Okay, actually, the neoplasm of the appendix have new classifications, and they are now called the epithelial neoplasm. To make it simply, this diagram, actually, this table picture, discuss what does epithelial tumor means. Here we have the adenoma, like any lesion in the bowel. Let's start with adenoma, so we can have adenoma of the appendix. It could be, this is about the epithelial. These are the epithelial tumors. It could be low-grade appendiceal tumor, mucinous tumor, or high-grade appendiceal mucinous tumor. It could be mucinous adenocarcinoma. We said adenocarcinoma can be mucinous, can be clear cell, can be Singlet ring cell, can be goblet cell, colonic type adenocarcinoma. Yes, the prognosis depends sometime on the subtype, but an interesting information that the prognosis doesn't depend on whether we found a perforated or non-perforated tumor. No matter perforation doesn't play a role in the prognosis. Okay, neuroendocrine tumor can be classified to classic or tubular. Other malignancies in the appendix, lymphoma, it's simply easy to manage with. We will discuss it in a few minutes. Metastases, especially from the ovaries, mesenchymal tumors such as GIST, desmoid, leiomyoma, leiomyosarcoma. Okay, you can guess anything. Kaposi sarcoma, HIV associated. Okay, schwannoma, neurofibroma. This is a neuroectodermal or nerve sheath tumor. The neoplasm of the appendix and their prevalence can be abbreviated in the word MAC, First of all, and the most common is the mucinous adenocarcinoma. A little bit we have adenocarcinoma and carcinoid. In the past, they think that the carcinoid is the most common. Now, mucinous adenocarcinoma is the most common. Okay, here another mucinous adenocarcinoma, followed by adenocarcinoma, carcinoid, then goblet cell cancer, and Singlet ring cell, which carries the worst prognosis. Have the lower prevalence or incidence. Here you can see that the carcinoid tumor have good prognosis, about good 5-year survival, about 83, whereas Singlet ring cell have 5-year surveillance survival of about 2018. So, okay, if we want to talk about adenocarcinoma, we see the clue information. The most important information is that if it is limited to the submucosa or mucosa, T1 well differentiated, appendectomy is enough. Otherwise, we proceed for right hemicolectomy. Some studies say that even in patient with more than T1 tumor, we can proceed just for appendectomy, and the survival is the same. But when we compare the risk of right hemicolectomy to the risk of lymph node metastasis, so it's better to proceed for right hemicolectomy. Here they actually want to remember you that this is cancer, so you have to do staging for similar to colorectal cancer. This includes CT scan of the chest, abdomen, pelvis. This includes actually MRI is helpful if you cannot proceed with CT scan. This includes colonoscopy. Actually, this is after the histopathological reports of an appendectomy comes back to you. You have to proceed with your investigations, with your staging. What else? Antigen, CEA, other tumor markers. If we have concern about the diagnosis, if the diagnosis is not clear, so we can order CA 125 and CA 199. Okay. The prognosis of appendiceal adenocarcinoma is strongly affected by lymph node metastasis and distant metastasis, and tumor differentiation. As we said previously, tumor perforation doesn't seem to have an adverse prognostic indicator. Okay, we said that the Singlet ring cell is the worst prognosis, mucinous and intestinal type intermediate prognosis, goblet cell favorable prognosis. Okay, we said the treatment of the adenocarcinoma, if it is limited to the submucosa, mucosa T1 differentiated, simple appendectomy is enough. Otherwise, right hemicolectomy. Okay. We already discussed if we found this is a challenging scenario. If we found on our surgery that we have a tumor with spontaneous perforation of an appendiceal tumor and release of mucinous material in the peritoneal cavity, what to do? We said we have to we have to do the 4 things: appendectomy, wide local excision of the mesoappendix, biopsy of any suspicious lymph node, cytology, washing for cytology. That's enough. Cytoreductive surgery is delayed, is a second procedure. Here is it. peritoneal washing for cytology, and biopsy of any suspicious lymph node. Formal cytoreductive surgery should be delayed later for senior, for specialized surgeon and center. Okay. The chemotherapy actually, the role of chemotherapy in appendiceal neoplasm is not well studied, is not cleared like colonic, but they actually mimic the colonic. We can use for stage 2 and stage 3 Volvox. Actually, there is a role for chemotherapy. Our Capox. Capox, this is capecitabine with oxaliplatin. Volvox, this is 5-fluorouracil, oxaliplatin, and leucovorin called Volvox. Doesn't matter. Yes, there is a role for chemotherapy, especially in stage 2, 3, some of stages 4, and that's all, I think. Okay, mucinous lesion. This is a mucocele of the appendix. We already discussed it. Let's say what they want to talk here about. Okay, and they just reviewed what we already said, and I think repetition is important. If we proceed for appendectomy and found mucocele of the appendix, we can proceed for simple appendectomy. If we have suspicious of perforation or peritoneal implants, we should do appendectomy, wide resection of the mesoappendix, lymph node biopsy, cytology, wait until the result, proceed if to cytoreductive surgery. If the lymph node is positive, we have on cytology cellular mucin, cellular, we have cellular and acellular. Acellular have lower risk for invasion, while cellular have high risk for invasion. And also lymph node, and if the margin is involved, we proceed for cytoreductive surgery. They just here review. This is one of the scenario that we can find the volcano sign called on colonoscopy. Actually, it's hard to predict the diagnosis before doing appendectomy, but in some cases we can do colonoscopy, and here we see the raised circumferential lesion with central amplification. This is called the volcano sign. It is pathognomonic for mucinous cancer of the colon or appendix. Okay. This is also a CT. You can see here that the appendix and the cecum have irregular border with suspicious calcification, so we can guess that this may be a tumor of the appendix. This is an ultrasound showing what we call it the onion appearance. This is also pathognomonic onion skin appearance. This is pathognomonic for mucinous neoplasm. What else we can add? This is also a CT scan showing, you can see here that something is not correct. It's hard to say this is mucocele of the appendix, this is adenocarcinoma, this is phlegma. Something is not nice here. Okay, the final result was what? Acellular mucin T4A. Actually, okay, we said that mucinous can be cellular and acellular, and this is why we take cytology. Acellular, low risk for invasion, while cellular, high risk for invasion. What to do? Some doesn't proceed to cytoreductive surgery and proceed to what we call it short interval surveillance. This includes CT, colonoscopy, tumor markers. Here you can see recommendation: a CT doing CT every 3 to 6 months with the initial 2 years for 2 year surveillance, and then every 5 year. Okay, actually, what we said about what's written here, I don't want to disturb you. What we already discussed when we talk about the mucocele of the appendix, acidomyxoma peritonei, is what's written here, except that they talk about the cellular and acellular type, and the new approach for surveillance, not proceeding for cytoreductive surgery. In some low risk patient, we can produce to low or short surveillance. This include CT scan, colonoscopy, tumor markers. Which patient? It's hard to say. Even here, they did not describe. They just said some studies recommend. That's not a classic information for students or for those who are preparing for their exams. Okay, neuroendocrine tumor. And about the neuroendocrine tumor of the appendix. And remember here that we are talking about neuroendocrine tumor of the appendix. We are not talking about carcinoid tumor and carcinoid syndrome. I think this needs a separate lecture. We are talking about what is in regard of the appendix. So I think a useful picture is to see this photo here. It will help us of how we can manage. First of all, we said even carcinoid tumor of the appendix, it is hardly to predict pre-op. It's usually incidental finding. We do appendectomy and then the histology comes back. Yes, there is certain laboratory testing we will see that can help us, but we usually see it after histopathology. We said that here we have a cutoff size 2 centimeter below and 2 centimeter above. If we talks above, so this means we need above 2 centimeter, we need right hemicolectomy, because they found the evidence of lymph node metastasis is higher if the tumor size is more than 2 centimeter while it's low. Another guidance for the treatment, they says if it's less than 2 centimeters, so appendectomy is enough. Another one, it says if less than 1 centimeter, appendectomy. Between 1 and 2, we have to look for these criteria: the mesoappendix invasion, location at the base, Ki 67 more than 2%, angio or neuroinvasion, or surgical margin is involved. If it's between 1 and 2, and one of these findings are found, we proceed to right hemicolectomy. Above than 2, right hemicolectomy without any criteria. So you can see here we have, if the size is more than 2 centimeter or size between 1 and 2, plus one of the following: mesoappendix invasion, location at the base, Ki 67 more than 2%, angio or neuroinvasion, surgical margin are involved. These all are histopathological information. We go for right hemicolectomy. If this is not present, if it's less than 1 centimeter, if it's between 1 and 2 centimeter and none of these findings are found, appendectomy is sufficient. Okay, what else we can add about the neuroendocrine tumor? That neuroendocrine tumor of the GI, you can see here. Let's go up a little bit. GI neuroendocrine tumor, the appendix is the most common site. It's more common in male. What else? Sorry, it's more common in women. It's more common in women. It's more likely to be on the tip. So obstructing type is rare. The symptoms is not specific. It's like appendicitis. Two to develop carcinoid syndrome, flushing, diarrhea, right side heart failure, bronchial asthma, we have to have liver metastasis, and the liver function is already exhausted, not working. The liver is not working due to metastasis, because if the liver is working, so that it can degrade the products of carcinoid tumor. These are the serotonin, bradykinin, so we will not have carcinoid syndrome. And actually, in the tumor of the appendix, it's rare to develop carcinoid syndrome. What else we can say or we can add? Let's move a little bit below. Here, the appearance, it's firm, yellow, pulpar mass. I didn't include any picture because even microscopic appearance is not enough to diagnose, but it looks like lipid, and for that reason, in the past, they think that goblet cell adenocarcinoma is a type of neuroendocrine tumor. Goblet is actually lipid rich, but now goblet is an epithelial tumor, is a subtype of adenocarcinoma. We say the majority is on the tip. This is not correct, that the mean size is 2.5 centimeter. Forget it. Okay. This is also another way of how we can, another way of reviewing how we can treat it. Up to 1 centimeter appendectomy is enough. More than 2 centimeter right hemicolectomy, and between 1 to 2 centimeter, this finding, we should proceed to right hemicolectomy, even if it's less than 1 centimeter. But the presence of invasion to the mesoappendix and lymph node involvement is less likely in the tumor less than 1 centimeter. Okay. This is what I said, that goblet cell carcinoid no longer considered neuroendocrine tumor. They think that it's a type of neuroendocrine tumor because it's rich of goblet cell, which is a fat rich, actually lipid rich cells. Okay. Some laboratory tests, yes, can help us. For example, chromogranin A, it helps us in detecting the tumor if it is more than 2 centimeter. Below, no. So if it's not, some literature says that, or some textbook says that, if it's not detecting on CT, so chromogranin A can help us. What else? Octreotide scan help us in identifying the extra intestinal location. What else? Chromogranin A, we said it can help us in diagnosis, and also it can help us in the surveillance to see the trend post-op, if there is recurrence post-op. So it is helpful. Okay, let's review what we didn't say about carcinoid syndrome. This is neuroendocrine tumor. Okay, we actually said that. Okay, octreotide scan, it helps us. This is the somatostatin receptor. It can help us in finding the appendix. Has been found to be ineffective if the tumor is less than 1 centimeter. Okay. Well, here I didn't want to disturb you, but gallium DOTA-TOC, it's another modality. We use it now to replace the octreotide scan. It's with higher sensitivity, called gallium or GA-DOTA-TOC scan. Chromogranin A, most useful biomarker in diagnosing the neuroendocrine tumor, but it should be larger than 2 centimeter. And it's useful in the screening. Yes, not screening, I'm sorry. sorry for that, it's not useful for screening, it's useful for detecting the recurrence of metastasis. This is not screening. Screening, it's when we want to discover the tumor before it's happened. It's useful in detecting the recurrence or metastasis after surgery. Okay. 5HA, this is a urine test, 5HIAA. It's actually useful when we have carcinoid syndrome, which is rare. Okay, what else? The staging is not that important, it doesn't guide our treatment actually. That's what about the carcinoid tumor. Other neoplasm, we said goblet cell carcinoid tumor, forget that. It is goblet cell tumor, a subtype of the adenocarcinoma. We talked about the clear cell carcinoid tumor. It's extremely rare. These are the tumor of the appendix. What tumor we have? Carcinoid, we already said. Primary adenocarcinoma of the appendix. Mucocele of the appendix leading to pseudomyxoma peritonei, we already talked about. Lymphoma is extremely easy and extremely rare. It's rare. We know that the GI tract is the most frequent extranodal site for non-Hodgkin lymphoma. If it's not the lymph node, so the GI tract, the stomach, I think. The stomach is the most common site. It's to be in the appendix is extremely rare. Primary lymphoma of the appendix is about 1%. The treatment of lymphoma of the appendix is appendectomy. Okay, the symptoms will be similar to appendicitis. Finding on CT is not specific, but you can see here appendiceal diameter more than 2.5 centimeters, surrounding soft tissue thickening. Is this sensitive or specific? No. Management is appendectomy. Right hemicolectomy is for tumor that extend beyond the appendix. Okay. And adjuvant chemotherapy is not indicated if the tumor is confined to the appendix. So this is all about the tumor of the appendix. I hope I delivered it in a good, nice way. I know that in some places it looks like it's not unclear. I try to make it clear. Thank you